following Dr. Shiv. So hopefully mine will be as exciting as his. I really enjoyed listening to him talk about ventricular arrhythmias. My topic today is a little bit different. I'm going to be talking about genetics, genetic screening, and genetic testing, the diagnosis and treatment of cardiac congenital arrhythmias. And initially this was supposed to be a debate, but I had a friend, and her name was Irene, and so my partner is not here. So you're going to just hear the positives about genetic testing today. Some negatives, but for the most part positive. Okay? So genetic testing had its roots back in the Venerable Watson and Crick era in 1953, when they first proposed the structure of deoxyribonucleic acid, when they said that they thought that DNA was a double helical structure. I just put a quote down there: "It has not escaped our notice that the specific pairings we postulated immediately suggest a possible copying mechanism for the genetic material." And so here's a timeline of genetics and genomics going from 1865, when Gregory Mendel sort of proposed the theory of Mendelian genetics, which is pretty much what we're going to be talking about today, followed through by Watson and Crick. And then in 1990, the Human Genome Project was started, the very audacious goal of basically categorizing the entire human genome. It was completed in 2003 to much fanfare, and the thought from us as scientists and clinical physicians is that this is going to help us in terms of treatment as well as diagnosis of all of these clinical disorders. And I just put in a slide here of what DNA looks, just to remind everybody from college and med school and such, of the DNA sequence and the how it turns the genetic code, basically these five letters here that in a certain code can turn into a protein. So as I said, by 2003, there's a lot of articles talking about genomic medicine, how this is going to change our diagnosis and treatment, and how the future of medicine will become much more personalized. Instead of a one-size-fits-all, it will be individualized to what your genetic code is. Just some quick facts about the human genome. There are 2.85 billion base pairs present in the human genome. Each single strand copy of letters would actually fill 400,000 pages. And if you remember, some common disorders like sickle cell anemia is typically caused by an alteration of a single letter or a single base pair. There are 20 to 25,000 genes that code for over 100,000 proteins, and really we are all very genetically alike. 99.9% are the same. There's about 1 in 1,200 base pairs that differ between individuals, and this differentiation, which this mutation, so to speak, which provides the basis of both evolutionary change as well as the clinical disorders that we can see today. These common terms, again, I know that you're probably all aware of these, but the chromosome is one of 46 distinct separate microscopic units of DNA that comprise the genome, and when we have difficulties with our chromosomes, such as trisomy 21, we will get the syndrome of Down. The gene itself is a sequence of nucleotide bases which carries information for constructing these proteins. And remember, it's only the exon portion of the genome that encodes for the protein. And in fact, only about 5% of an actual genome makes protein. The rest of the stuff is modulators and introns and stop codes and things like that. Genomics, which we've already touched on, is the study of the organism's genetic material and its function. And polymorphism, which is a somewhat important term to know about when we start talking about genetic testing, is the individual, the variation in genes that we see within individuals in the population, totaling more than 1% of the population. So these are just average variations that we see in people, not necessarily pathologic in nature. The most common of these are the single nucleotide variations, or the SNPs, as we call it. And our challenge when we start talking about genetic testing is how to differentiate between these very typical genetic polymorphisms and an actual pathologic mutation. So this is how, if you recall, how a DNA gets turned into a protein. Your DNA will unravel and then use messenger RNA to make a new messenger, I guess, an RNA, which comes out of the nucleus using a transfer RNA to make a protein. So there's a lot of steps here which can get messed up and which can cause our mutations. This is just a quote I put in from Eric Tobel back in 2007, it looks like. Again, describing the enthusiasm and the promise that we hope genomics will provide for us in terms of treatment of our patients. Now, when we start talking about genetics, we want to differentiate between monogenic and complex or multigenic disease, and primarily today we'll be talking about monogenic. But as you know, monogenic disorder is a single gene mutation that leads to disease. And you can see here, there's an inheritance pattern involved, either an autosomal dominant or recessive, or a X-linked, depending on what type of disorder, what type of inheritance pattern. But the risk is the same within the population, and the risk within different families, whether you're Asian or Indian or African American, is the same. So in these monogenic syndromes, a single gene mutation can cause a disease phenotype, and these are the ones that are most amenable to genetic testing. We have to remember the difference between a genotype and a phenotype is that a genotype is the actual mutation, whereas a phenotype is the clinical presentation, the clinical disorder. Our registries that we have available today tend to be biased because only the more sicker symptomatic patients will actually show up and want to be part of registries. The penetrance of the disease is the extent to which the individual with the same genotype has the same phenotype. So not everybody with a long QT genotype is going to have a long QT phenotype. And I've just put a couple examples down here about the penetrance in hypertrophic cardiomyopathy is about 90%. So 90% of patients who have that mutation will actually have the clinical syndrome of hypertrophic cardiomyopathy, as opposed to Brugada syndrome, where only 30% will exhibit the clinical disorder. Expressivity is a little bit of a different concept. We were talking about variations in the phenotype and similar mutations. So some patients with Brugada syndrome have ventricular fibrillation. Some of them present with SVT or atrial fibrillation. It's the same mutation, and they have a clinical phenotype, but it is slightly different. Okay, so these are the cardiac ion channelopathies that we know today. The long QT syndrome, both Romano-Ward syndrome as well as Pierre-Bell-Lang-Nielsen. That's Anderson-Towle syndrome, Brugada syndrome, let's go faster, idiopathic ventricular fibrillation, familial AV conduction block, short QT syndrome, catecholaminergic polymorphic ventricular tachycardia, drug-induced torsade de Pointes, sick sinus syndrome, let's go faster, familial atrial fibrillation, sudden infant death syndrome, sudden unexpected death syndrome, and Timothy syndrome. That's it. Dilated cardiomyopathy. All of these disorders have been linked to a genetic abnormality. These are the concurrent clinical indications from the AHA for genetic testing. You can see that across the top are the most common genetic disorders that we deal with as electrophysiologists. And you can see that evaluation for clinically suspected disease, there's a positive all the way across, whereas if you look underneath for pre-sports participation, as well as universal screening, there are no indications for genetic testing. Okay. So what are the benefits of genetic testing? You'll see that the benefits can be separated into three different parts. Diagnostic, so perhaps there's an unexpected death in the family, which causes a lot of grief, obviously, and a lot of concern. If you can genetically test either the proband, the person affected, if they survived, or a family member, then you could proceed with cascade screening, meaning testing the incident case and then identifying the genetic mutation and then testing all the other family members based on that one specific genetic mutation. Again, as I mentioned before, there's variable penetrance and expressivity, so even though mom doesn't have the same symptoms as the daughter had, we still would want to know whether mom has the disorder. We can figure that out with diagnostic genetic testing. There are prognostic implications with genetic testing, both with reproductive planning, as well as the relative risk of sudden death, and I'll show you some data regarding that, as well as therapeutic implications. With certain genetic mutations, we might change our surveillance, drug, or device therapy, and obviously there would be earlier treatment given to genotype positive individuals. There are pitfalls, however, and the pitfalls include the locus heterogeneity. There are many, many different mutations that can cause the same genetic disorder, many of which we don't know about. And I've again listed there a couple of the examples. Hypertrophic cardiomyopathy, only 30 to 40% of genetic causes have been elucidated, whereas long QT, we think about 65 to 70%. And negative tests does not rule out the genetic disorder, which is, I think, the hardest thing to remember with genetic testing. Just because you're negative doesn't mean you don't have it. The real usefulness of genetic testing is if it's positive. And then, of course, there's the issues in insurance and employment discrimination. In 2008, there was the GINA Act, Genetic Information Non-Discriminatory Act, which basically said that insurance carriers could not discriminate and employers could not discriminate against patients who had genetic abnormality. Unfortunately, this act did not extend to disability or life insurance, primarily just covered health insurance. So I think there are still some holes from that aspect. And then there's the duty to warn litigation. There have been a few cases in which family members have brought litigation against the physicians for not notifying them of another family member's positive genomic testing. So we have all of those issues to deal with genetic testing. There are available testing sites both academically as well as in the clinical setting. Academic centers will typically take longer, anywhere between 6 to 24 months, depending on what study you're in. You may not ever know the results of the test, but it is pretty much a voluntary thing, so the cost is very low. Again, the tests are not validated by the FDA. Whereas in a clinical setting, it's a fee-for-service program, so the turnaround time is much quicker, anywhere between 4 to 8 weeks, but is costly. I think the average panel is about $5,000 now, but on the flip side, all of these tests meet strict quality control and proficiency standards. And then again, you can perform that cascade screening that we talked about. So this is just a website in case you wanted to look up some genetic information resources, particularly if this particular genetic mutation is being tested. So I put this slide in because I think this is probably the most important part of genetic testing, is pre-test genetic counseling. When I have a patient that comes in with either a confirmed or suspected genetic abnormality, we'll usually have them meet with the genetic counselor first before I see them, and then whatever testing needs to be done at the time. We're trying to get the whole family in at the same time, or with as many members as possible, so that the genetic counselor can go through limitations, benefits of testing, alternatives, talk about reproducible planning, as well as the possible results. Because unfortunately, again, genetic tests are not straightforward. Typically, at the end of the day, the genetic counselor will meet with the patient and the family again to make sure that there are not any other questions that are hanging around and have not been answered. And these are the result possibilities when you get a genetic test. Positive is a class 1. Positive is class 1 considered where if the patient is affected, you have to treat per guideline. Class 2 is kind of that uncomfortable, well, there's a mutation there, but we don't know what it means, so to speak. And then class 3 is probably not a mutation, it's probably just a genetic polymorphism. Again, you have to always ask yourself, and you have to put this in the clinical setting, is it a true negative? Do you believe the negative, that they truly do not have the disease, or would you consider this a false negative, and the test has simply not identified the genetic mutation, and the patient still most likely has whatever genetic disorder you're treating? Okay, so class 1, as I said, is deleterious or probable deleterious mutation, and the genetic change causes a protein that's either not made or a protein that's degraded early, or the genetic change is present in a vital part of the protein. Class 2 result is a variant of uncertain significance, and either the genetic change is not in a vital part, or it does cause a splice site variant with some sort of genetic change, but we're not sure if it's actually causing the mutation. The genetic change seen in a class 2 has to be pretty rare. It can't be one of the common, quote, polymorphisms. And then class 3 is a protein altering variant that is of common frequency, or it's rare, but there's no evidence that it would cause anything bad to happen with the protein itself. So what I would say for access to genetic testing is we need to be careful about the selection of these patients. Selection needs to be based on the clinical presentation itself, what probability you think the patient has this disorder, and what can you gain from the test result. And again, we'll talk about that some more, but somebody with hypertrophic cardiomyopathy, the test results, there are no indications at this point to implant a defibrillator based on genetic testing alone, as the patients typically have to have symptoms. Also, we have to discuss cost. These are expensive tests. They are most often not covered by the insurance company. I know that because I've talked to many of them. When you start talking about cost assessment, long QT syndrome is actually the most cost effective. And the least cost effective is actually testing asymptomatic family members of a sudden cardiac victim. So this was a study done back in 2009, and you can see I've sort of put some stuff in red here. This is a confirmed diagnosis long QT. So clinically, you feel the patient has long QT syndrome, perhaps their QT interval is 550 milliseconds, or they've had syncope and reported ventricular arrhythmias. The cost effectiveness, it costs approximately, you can't see it from here, but maybe $8,400 per test with a 65% positive genotyping. Versus this one here, which is idiopathic via family member sudden cardiac death, you can see that the success of testing is quite low, 2%, and it costs roughly $221,000 for that test. So again, another thing to think about when we start ordering testing. So we are going to take a minute to talk about 2 specific disorders that I think illustrate the use of genetic testing best. Long QT will be the first one, and then Brugada syndrome if I have time. Okay, so long QT syndrome was first described in 1957 by Trizella and Nielsen, followed quickly in the early 1960s by Ramon Ward. The first long QT syndrome chromosome locus was noted in 1991, and back in 2004, testing and then commercial testing became available for the mutations in long QT. The incidence of long QT is 1 in 2,500. We think that it represents 20% of autopsy-negative sudden cardiac death and 10% of SIDS. This is a disorder of reduced penetrance, so again, you could have the mutation but not have the clinical syndrome. It also has variable expressivity. They are mutation-specific because there are different types of long QT genetic mutations, and they specifically have different triggers, different prognostic data, and different treatment. Unfortunately, genetic testing identifies only 75% of mutants, but this is actually the highest yield test that we have of all the monogenic arrhythmia syndromes. Congenital long QT, as it says, the QT interval is prolonged in these patients, and they typically will present with syncope, seizure, and sudden death. And their syncope, seizure, and sudden death is due to this arrhythmia, torsade de fond, on the bottom, which I'm told is French for twisting around the baseline. And you can see a lot of cases are not this clear, but in this particular EKG, the QT interval is very abnormal, and the T wave is actually falling into the P wave here. As I said before, that's not everybody with long QT mutation. Approximately 33% of gene-positive carriers have normal QT intervals, and this is just a plot looking at what's considered to be normal, 440 milliseconds, the long QT versus the normal. I will say that the normal for women is probably a little bit longer at 450 to 460 milliseconds. The molecular basis of long QT, and this is a very busy slide, but I will just quickly review because I think it's important. anything that prolongs this action potential duration, so the excitability of a calcium or a cardiac cell, phase 0, the sodium comes in and depolarizes the myocardial cell, followed by this ITO current, which is an outward potassium or repolarizing current, and then phase 2 to 3 is manifested by somewhat of a balance between depolarizing calcium currents and repolarizing potassium currents until you get back down to baseline. So anything that disturbs this action potential or this interplay of ions will cause the action potential to get wider and thus cause the QT to prolong. And we see this because the abnormalities in long QT are primarily centered around the potassium channel, but there's also the sodium channel. So these are all the long QT susceptibility genes, and you can see if there's a bunch of them. This one's actually a little bit old. There's a couple more out there. Most of them are associated again with arrhythmias, ion channels, excuse me. There are a couple that are scaffolding proteins, a couple modifiers, like anchoring has nothing to do with the ion channel itself. These are modifiers. So we're learning more and more about long QT. These are the actual abnormalities that are tested commercially, and you can see that they account for probably about 75 to 80%, and that's where we get that 75% number from. So what are the genotype-specific triggers? And you can see here that long QT1, the classic presentation is that they passed out during swimming, whereas long QT2 is an emotional event, whether it be the alarm ringing in the morning or a sudden becoming upset about something, whereas long QT3 is typically seen during sleeping hours. Okay. And here's some of the data to suggest that exertion, long QT1 versus swimming, also long QT1, and then you see that auditory hallucinations in long QT2. Okay. And then the EKG patterns with these long QT singers also are different depending on the mutation. The T wave looks different. The T wave in long QT1 is this peaked T wave versus the biphasic T wave in long QT2. And then a lot of people say the T wave in long QT3 is kind of an asymmetrical. The probability of cardiac events is also different depending on what long QT mechanism you have. If you look at this slide, you can see that the probability of events in long QT3 is much lower than long QT1, but if you actually look at percentages, the probability of dying, which is on the right-hand side, is probably a little bit higher in long QT3 versus long QT1. So from this, we can make a little bit of a pyramid diagram saying which patients are at the highest risk. If your QT interval is long, or if you have long QT1 and 2, or if you're a male with long QT3, you're at the highest risk versus QT intervals less than 500 milliseconds, and males with long QT2. So in this respect, the mutation, knowing the mutation kind of helps us give an idea to the patient of their risk of dying suddenly. Also, the effect of beta blockers is different depending upon your mutation. Long QT1 is considered to be, beta blockers are considered to be first-line therapy, whereas there is no data to suggest that long QT3 is affected in any means by beta blockers. So you may have a patient with long QT3 and not know that they have the long QT3 mutation, and you give them beta blockers thinking that that's going to help, when really that is not going to be beneficial. There's also intragenomic long QT risk stratifications that we see. So within long QT1, long QT2, and long QT3, we can see that there are differences in prognosis based on mutation type as well as mutation location. So long QT1 transmembrane defects. So a defect in which where it occurs somewhere in that transmembrane portion, this portion, and these are incidentally all the mutations in long QT1 that have been discovered. So you have mutations that occur within that transmembrane area, and then you have ones that are on the little tails, the C-terminus and the N-terminus. And we know that in patients who have the transmembrane type of mutation, the probability of cardiac event is much higher than if your mutation is on the C-terminus. So location and function, Your hazard ratio is greater than 2 for dying suddenly if you have this, and perhaps as a clinician we would want to treat these patients more aggressively with defibrillator therapy. This is a long QT2 associated mutations, and you can see again the number of documented mutations that have been discovered. In long QT2, the poor mutations are the ones that behave poorly, as we say, and there is an increase again in the risk of death associated with these poor mutations versus in the C terminus or the N terminus. We also have to be a little bit concerned about, again, these genetic polymorphisms. In about 4% of healthy whites and blacks, you will see this mutation, which is gray, show up. So do they have long QT2, or are they just plain old genetic polymorphisms? So again, this is sort of the pitfalls that we see when we start talking about genetic testing and whether you want to label somebody, oh, you have long QT2, when in actuality about 4% of the population has this particular mutation, but yet it's never exhibited signs of long QT2. So for long QT2 syndrome, for me, this fulfills appropriate criteria for genetic testing. There is a diagnostic portion to this where the genetic test yield is adequate, 70 to 75% mutations. The prognostic data is helpful in looking at poor versus C terminus mutations, also to assess ion channel function and help with reproductive decisions, and it assists with treatment decisions. If you have a long QT3 patient, you may not have to tell them that they can't do any exertional activity, because really their trigger is sleep and not exertion. You may also choose not to treat them with beta blockers, because again, there is no reported benefit to beta blockers in long QT3. And again, more aggressive treatment in the higher risk individuals. Brugada syndrome, which I will talk about just quickly, is another genetic disorder described in 1992, associated with ST elevations in the right precordial leads, and the prevalence is estimated to be about 1 in 5,000. It is thought to contribute to about 10% of total sudden cardiac deaths and 20% of deaths in patients with structural normal hearts. This disorder has also been discussed in association with sudden infant death syndrome and sudden unexpected nocturnal death syndrome, which is fairly, I don't want to say common, but they see it more often in young males of South Asian descent. Okay. 20% of Brugada patients develop SVT. So again, there's that variable expressivity piece to this. AFib is seen in about 10 to 20% of patients, and ABNRT as well as Wolff Parkinson White syndrome have been described. Again, there's that predisposition for nocturnal events. It is an autosomal dominant transmission. SCN5A is the primary gene responsible, so it's a sodium channel defect where you get loss of function of these sodium channels. And it's interestingly the same defect that you see in long QT3, except in long QT3 it is a gain in function. So the channel is working in the opposite direction when you have the Brugada syndrome mutation versus when you have the long QT3 mutation. They cause short-coupled PVCs in phase 2 reentry, causing ventricular fibrillation. And again, this is just a slide kind of describing the difference between long QT3 and Brugada syndrome. So we used to think that all of Brugada was due to this SCN5A mutation, but now we're finding out that there is also genetic heterogeneity in Brugada syndrome. There's some papers that have been published looking at other mutations that could cause the clinical phenotype of Brugada syndrome. The EKG manifestations are pretty classic and probably the best way we have to diagnose this. I have here an example of a type 1 as well as a type 2 Brugada. And you can see in the type 1 you get this coding ST elevations of greater than 2 millimeters. This is pathognomonic for Brugada syndrome and considered a type 1 EKG. Versus this a little bit more non-specific saddleback pattern, as we call it. Then there's also a type 3, which basically looks the same, but it doesn't make the millimeter criteria. This is a 12-lead EKG of somebody with Brugada syndrome, and you can see that they have the classic type 1 EKG in V1 and V2. So in terms of diagnosis, typically for Brugada, it's a type 1 EKG pattern, and this is associated with documented ventricular fibrillation, ventricular tachycardia, and family history of sudden death before the age of 45. Inducible VT with electrophysiology studies thought to be a marker for increased risk, as well as syncope and nocturnal agonal respirations. Unfortunately, the EKG with Brugada can be very dynamic, and we typically will see the type 1 pattern in febrile states, hypo or hyperkalemia, as well as with alcohol or cocaine toxicity or post-cardioversion. And the way that, one of the ways that we can try and discern whether these patients have Brugada is to do something called the procainamide challenge. Now remember that procainamide is a sodium channel blocker, and if you have Brugada, your sodium channels already don't work so well. So adding a sodium channel blocker to a person who has decreased sodium channel function should induce that type 1 ECG. And there's a specific protocol that we utilize that's typically done in the intensive care unit setting where we give procainamide infusion and monitor them for up to 120 minutes, looking for these EKG changes. The study is considered negative if there's no positive provocation at 3 hours. The prognosis in Brugada syndrome is a little bit different. 8.2% of patients will experience sudden death or VF during follow-up. That's a pretty high number in 2 years. And just the presence of the spontaneous type 1 ECG carries a 7.7-fold higher risk of developing arrhythmia. And male gender is also considered to be a risk factor. Patients that have sudden cardiac death are at the highest risk of recurrence. It's kind of a no-brainer. You know, you got to put a defibrillator in these patients. The ones that are difficult are the patients with syncope and spontaneous type 1 ECG. Again, their risk of having recurrence is quite high. But then you've got this 8% recurrence in asymptomatic individuals. And it's been thought that the presence of the type 1 ECG is really kind of the break point whether you start to think of whether this patient needs to be followed closely. Genetic testing in Brugada syndrome, the yield is very low. It's about 25 to 30%. We're only testing that sodium channel mutation at this point. However, it does provide diagnosis confirmation as well as family screening. The only treatment is a defibrillator at this point. There are no medical therapies for it, and we can often determine the prognosis on our own with the things that I mentioned previously, type 1 ECG, syncope, and the positive EP study. So because of that, Brugada syndrome is not considered to be a great reason to pursue genetic testing. Certainly we can give diagnostic information to the family as well as the patient, but we cannot provide any therapeutic assessment. We can't change the therapy based on the results of the test, and prognosis is sort of something that's still being looked at right now. So in conclusion, inheritable monogenic arrhythmia syndromes are a major cause of unexpected sudden death. And these, the presentation, the prognosis, and treatment will vary depending on the genetic mutation involved. We should not pursue genetic testing without appropriate pretest suspicion. And again, I always think to myself, what is this going to do for the family? Will it help to have a positive test? Will it affect our treatment plan? Some disorders, such as CTDT, catecholaminergic polymorphic ventricular tachycardia, as well as Brugada syndrome, there's not a lot that we can gain from a positive test other than to tell the patient this is what you have. Unfortunately, if the test is negative, I don't think we can tell the patient this is not what you have. I think all we can tell them is we don't have any of the disorders that we know about already. I think in the right patient population, genetic testing can be helpful in tailoring an effective, comprehensive treatment program for the individual as well as their family. And I'll just leave you with this quote: the future of medicine will be preventive, predictive, preemptive, and personal.